When we talk about the medical village or the medical neighborhood around a patient-centered medical home, a primary care medical home, we're really talking about the specialty providers, the ancillary services, and every piece of that healthcare universe that surrounds that medical home. Well, if we want to communicate well with them, we have to first define what is it that those other pieces of the medical neighborhood need from the primary care medical home, and what is it the primary care medical home needs back. How do we develop successful bi-directional communication? It's the fundamental piece of getting great outcomes, of really delivering on this medical neighborhood concept of patient-centered, team-based collaborative care. The way you do it, start with a framework document. Share it with the neighborhood around you, everyone you work with. Share the framework of what it is you expect when you send a patient to another part of the neighborhood. What is it you expect back? What is it you expect in terms of access for your patients as they go to the other parts of the neighborhood? What is it, the data you want back about what they've done with the patient and how to communicate it? Great communication is the fundamental piece of two-directional data flow that defines great outcomes. It's more important than anything about managing transitions of care. And if we manage transitions of care, we know that is the number one predictor of patient trust, of patient adherence, and of, therefore, great patient outcomes. So what specifically do we expect in the medical neighborhood when we send a patient to someone else down the street, so to speak? We expect great access. We expect timely communication about what was done in evaluating the patient and then in intervening with the patient. What we expect is a parallel style of care, not serial care. So what's the difference? Historically in healthcare, when someone referred a patient, for instance, from primary care to a specialist in what was then the neighborhood, prior to the medical home concept, prior to the medical village concept, what would happen is the patient would be told, would be getting either verbal signals or cues or indirect signals or cues that their primary care home was stopping their care at the point they went to the specialist, and the specialist would take over, and then after the specialist was done, then the primary care home would come back in. Serial care, that was called, S-E-R-I-A-L. Well, what's wrong with that? What's wrong with that is it is not team-based, it is not efficient, and we have scientific implementation science research which shows us that that's not the best way to get patients great outcomes, nor give them a great experience. So what's parallel care? If I'm the primary care physician and I'm the family doctor sending the patient to a specialist for a consult, what I say to the patient is, I'm going to continue to take care of you with this condition that I need help with and your comorbid conditions, but while you're at the specialist, we're both going to take care of you together. We are both going to communicate in both directions about what we each need to know from each other, what's happening with the patient. Imagine the importance of that when we're dealing with comorbidities. If I don't communicate in a parallel fashion with the specialist in the medical village while they're taking care of my patient and I'm the primary care doctor, the family doctor, then how are they going to know what's happening with the comorbidities? A much more effective team-based style of care in the medical neighborhood concept. That's the beginning of that framework I was talking about how to expect what we need and some of the specifics around what we need when we actively manage the transitions around the medical neighborhood.